All right, thanks for joining us for our lunch session. I'm Kelly Peck. In addition to wearing my research hat, I'm also the Director of Clinical Operations for our UVM Center on Rural Addiction. Dr. Gail Rose is going to be presenting here during this next hour. Dr. Rose is an assistant professor in psychiatry here at UVM and one of our core faculty for the UVM Center on Rural Addiction. I've had the privilege of working with Dr. Rose over the past couple of years on a couple of projects that she'll be talking about today. She directs both the best practices core and the clinical and translational core as part of our center, and she focuses her efforts on supporting community practitioners to obtain resources and the expertise that they need to better treat individuals with opioid use disorder. As a researcher, Dr. Rose has directed and contributed to projects broadly focused on clinical health services and patient self-directed care for behavioral health, chronic disease, and substance misuse. In particular, her work is focused on the application of various technologies to the identification and treatment of substance misuse in outpatient settings, and on the integration of behavioral health and primary care. Dr. Rose received her PhD in clinical psychology from the University of Iowa. Take it away.
Thank you. Thanks for spending your lunch hour with me. I think this is probably audible. Yes. Okay. So as Kelly said, I am one of the faculty at the UVM Center on Rural Addiction, where we do focus a lot of our attention on harm reduction. So I want to present just a little sliver of the things that we do in CORA and some of the things that we do that are a little innovative. Okay, I have no conflicts of interest. A couple things that I'll talk about are just defining harm reduction and strategies for substance use disorders, and then to describe CORA's innovations in providing harm reduction resources in Northern New England. At its very basic fundamental level, harm reduction is any action that reduces risk and increases personal and public safety. So if our goal was 100% safety all the time, we would live by these rules. We would not have electricity in our homes. We'd never ride a bike, never drive a car, never cross the street, never get in a boat, never go outside on a sunny day, or never get closer than 6 feet to another person. However, society has decided that there are potentially harmful or fatal behaviors that can be mitigated by protecting people while they do them. And in most cases, these are mandated. So we have smoke detectors in our homes. We have bike helmets, protected bike lanes, seat belts, speed limits, walk and stop signs, life jackets, sunscreen, and surgical masks. When people talk about harm reduction, usually they mean harm reduction when it comes to drug use. And so there are many different definitions. The most simple definition comes from the Department of Health and Human Services, simply helping people where they are without judgment, stigma, or discrimination. But we have definitions from NIDA, SAMHSA, ASAM, and WHO. They're all, overlapping, distinct, more or less detailed. So I'm not going to read them all, but these are some basic concepts of harm reduction. It's an evidence-based set of guiding principles, practical strategies, and policies that are aimed at reducing the harms associated with drug use. It's a model of care that accepts, for better or worse, that licit and illicit drug use exists, and it doesn't seek to condemn or ignore. It acknowledges that abstinence is not the only option for people to improve their lives, and any positive change can be harm reducing and therefore can be acknowledged as helpful. It's a person-centered approach that looks at the whole person, not just the drug itself, and it provides judgment-free support. It's a bridge to treatment and recovery when the person is ready. It can be something that kind of gets somebody ready, potentially in some cases. It is a model that encourages the input of people who use drugs in determining policies and programs. And it can also be a set of interventions. So as you know, prevention and treatment lie on a continuum. And there is really no solid line between harm reduction and treatment. They do overlap. And then when you think about, harm reduction can be considered along the whole spectrum that, for primary prevention, you're wanting to prevent the harm of any use in, youth who shouldn't be using it all. In secondary prevention, you're trying to prevent drug use disorder. And then by tertiary prevention, you're trying to reduce harm by reducing overdose and death. So it's all on a spectrum. Oh, so I have, in the words of a prescriber who kind of sums this up really well, excuse me, philosophically, from my perspective, I think harm reduction makes my life a lot easier and relieves a lot of my own suffering, where I don't have to fret about any moral judgments or what I think is best for somebody. It makes my job of meeting someone where they're at much more attainable. And specifically, just one example that's coming to mind is somebody coming in and asking for a short bridging prescription of Suboxone. So we've been having focus groups of individuals to help guide our work on barriers and facilitators to providing MOUD and other harm reduction services to the community of rural practitioners. So in practical terms, harm reduction for substance use disorders often looks like this. Naloxone or Narcan, the overdose reversal drug that can be administered by anyone. We have samples out in the hall, and please take one. We encourage everyone to have it, carry it on your person, never know when you'd be in a position to use it. And I will tell you more about the distribution of naloxone in a minute. Also, fentanyl and xylazine test strips can be used to test a small sample of an unknown substance to see if it contains fentanyl or xylazine. The idea being, once somebody has that information, they can choose whether to use or not use that substance and whether they might want to change their behavior around using it with someone else or in a smaller amount or various things. And wound care supplies are especially important now in the age of xylazine that creates terrible wounds, and people who don't have access to medical care, even basic first aid, do need supplies. So CORA does distribute all three of those, but other ways that harm reduction is kind of operationalized is through sex education and STI testing and condom distribution, HIV and HCV treatment and testing. The Good Samaritan laws are the laws that say, if you go seek treatment for someone who is having an overdose or having problems, complications due to acute drug use, that you can't be prosecuted for that, because that will prevent people from abandoning someone if they don't want to be at risk of legal action if they provided the drug to that person, for example. And then medications for SUD. So interestingly, like MOUD is considered to be the standard of care for opioid use disorder. And yet some people see it as harm reduction and not necessarily treatment. CORA does consider it treatment. And yeah, we have, so in our, I've mentioned that we do surveys and focus groups of individuals in our target area. And we have found that some providers do think of MOUD as replacing one drug with another. And we try to, communicate and educate people about that. But it's also the case that one of those drugs is potentially fatal. The other one can save your life and improve your life. So if that's really what it is, if it's replacing one with another, I'm all for it. Okay, there is, this is just very brief. There's a literature on this. It's not really my, intention today to go through all the literature on it, but we do know that naloxone distribution and education does reduce overdose fatalities. We know that MOUD reduces overdoses and all-cause mortality. It improves retention in treatment and reduces infections, complications. And MOUD and needle and syringe exchange programs reduce HIV and HCV transmission. Fentanyl and xylazine test strips are new enough. There haven't been randomized trials. There's no like real conclusive evidence, but at least anecdotally, people do use them and they do affect people's decision-making around how to change their behavior. And then we have other interventions just with alcohol, for example, efforts to reduce drunk driving have decreased motor vehicle accidents and other injuries. So now I want to talk a little bit more about CORA. As I mentioned, we do a lot with harm reduction. We, just to give you kind of the larger context, we are one of 3 rural centers of excellence that are funded by HRSA, the Health Resources and Services Administration. And this is our slide with the other 3. So we are empowering rural communities with evidence-based resources that support their efforts in SUD prevention, treatment, and recovery. And the 3 different centers each have a different focus. So for prevention, University of Rochester is focused there and on stigma. CORA at UVM is focused on treatment and harm reduction and other things. And then the Fletcher Group in Kentucky focuses on recovery, and recovery housing in particular is a strong focus of theirs. So we're guided by our mission we seek to expand substance use treatment capacity in rural communities by providing consultation, resources, training, and evidence-based technical assistance to healthcare providers and community organizations. So why focus on opioid treatment in rural areas? Well, despite the efficacy of MOUD, only 22% of Americans with OUD received treatment in the past year. And while office-based buprenorphine is compatible with rural, sparsely populated areas, treatment remains underutilized, especially in rural and remote areas, where over half of the counties lack a single provider, and providers also often only treat a small number of patients with OUD. We conclude that innovative approaches are urgently needed to expand access to evidence-based treatments for OUD in rural areas. Again, this is, in the words of somebody from one of our focus groups, the stigma and the lack of access and the poverty all kind of roll together to make it very difficult for people to do what they really, I think, want or are trying to do. So I'm showing this slide just as a representation of CORA does more than what I'm going to be talking about today. You don't need to pay attention to the words here other than to know that I'm going to be talking about the best practices core. There's 3 others. Happy to talk more about those, afterwards some other time. But so the one best practices provides technical assistance to support rural practitioners and community partners in implementing evidence-based practices. And secondly, it provides supplies, resources, and training in new and expanded models of care and delivery. The best practices core provides technical assistance in the form of harm reduction supplies and other supports to health professionals and organizations. And this is basically the process that we follow. So we get requests from individuals in the community we have a website forum. People can request, sometimes they send an email to ask for our services. And then members of our staff will meet with the requester to identify what their unique needs are, understand their organization, what are the issues that they're facing, what is their population, and then kind of match up what they need with what we can provide as far as supplies and referral maybe to our other cores that offer expertise through consultations with experts or offer presentations and things like that. And then we also have access to the other rural centers of excellence at Rochester and Fletcher Group in Kentucky to refer people to, in addition to just other things in the community that we're connected to. Just to give you a sense of the kinds of things I'm talking about with technical assistance, we have a number of different organizations that request services from us. So we have syringe service programs, recovery centers, peer counseling centers, HIV and HCV resource centers, and then MOUD providers, which includes OBGYNs, and family practitioners who manage MOUD treatment. Topics of discussion, this really is a tip of an iceberg. We could, I could write a whole story about the types of things that we talk to people about, but barriers to treatment access is common across pretty much all rural areas. And trying to help people problem solve around how do you get treatment and help to the people who need it, given the limitations of your area. Harm reduction, of course, stigma reduction, incentive-based behavioral interventions for stimulant use, tobacco use among MOUD patients, and alcohol use. Those are some of the top ones. One of the primary supplies that we deliver is naloxone. And I'm sure you all know it is a safe and effective drug that can be administered by anyone in the community with some instructions as to how. It's a competitive opioid antagonist with high affinity for the mu opioid receptors, kind of the mechanism. The onset of action depends a little bit on the manner in which it's administered. So we distribute intranasal naloxone, but it can be administered by IV or IM. It lasts anywhere between 20 and 120 minutes, really big range. Precipitated withdrawal is a risk or does often happen, and it can last for 30 to 60 minutes. The instructions, there's training and instructions available. You can go to the Vermont Department of Health website to watch videos and I think request live trainings, and always administer the dose, then call 911. So we distribute boxes of naloxone, but we do have this tried and true method of delivery of of our substance. And anyone who is like a Gen X or boomer who's in the room will know that they used to sell cigarettes in vending machines that look like this. This one, in case you can't see it, indicates that a pack of cigarettes is $3.50, quarters only. And there's a no tobacco tax sign, sticker in the corner with all the assortment and the array of different cigarettes that you could purchase. I saw one of these for the first time when I was in the YMCA going for swim practice as a kid. And, you're a kid, it's a really cool, you can pull the knob, and all of us wish that we had $3.50, which was, huge. That was like 5 allowances or something. And, trying to get one out was always our hope, and just, pull on each one. But that to me communicates like kids are interested in this. It's in a place, the YMCA, where like people are going for health, healthy reasons. So things have changed in our community as far as what we see that should be available out in the public. And then kind of today's average vending machine full of processed foods that we know also aren't good for you for the most part. And yet on the right, you can see this is our harm reduction vending machine. We have funding from HRSA to give 5 vending machines away to rural areas that need them. And they're stocked with naloxone, intranasal naloxone. And we've been able to distribute 4 of them so far. The first one is in northern Vermont in a like a health, just a regular health center. The second one was actually up at a health clinic in a federally recognized tribal reservation in northern Maine. A third one was at a health consortium in western New Hampshire, western New Hampshire. And then we just did one at in southern Vermont at a recovery center. And then we have one more that's going in Maine, which is like a health justice organization that provides service and advocacy for people with HIV and people who use drugs. And I want to show you, like, these are pretty savvy, sophisticated machines that can that have certain features. So for one thing, they are climate controlled. They have electricity. We have to find a place where you can plug them in, because in northern New England, you have extremes of cold and heat, and you want to make sure the product stays within the range where it's going to be efficacious. It can be personalized. So depending on the product that the person wants to, just like you see in in the snack machine, you have a different size for the candy bars, the chips. They can, if they want to have test strips, for example, they would have a smaller coil, and those can be swapped out or in time if changes were made to the products they want to put in there. It is personalized in terms of the wrap as well. You can't see the side, but every organization has their own logo that gets kind of wrapped around the machine, and so it's pretty slick looking. And also, we can obtain data so that it's electronic in the sense that we have access to the dispensing data. So how often somebody acquires a dose and how often, like which days of the week and what time of day. So I have one of our, more eager students, the practice in New Hampshire has shared with us their dashboard for how they represent the data of usage of the machine. This is very sophisticated. Usually it's a spreadsheet, all the other ones are sort of, here's our spreadsheet of, it's like raw data. But they have an imaging person specialist there. And the interesting thing, so on the upper left, I am going to use my, you will see this is the state of New Hampshire with, minus a couple of the counties. And Grafton is the county that Littleton, New Hampshire is in, and that's where the machine is located. What the programmer was able to do is when people go up to the machine, they can enter in their zip code and it's not identifiable. And when they enter their zip code, then that gives data that they can map on to see where are these people coming from who use the machine. Obviously, 70% of them are from the county that the machine is in, but there are several from the county above, Coos County, and then just, a few, 1 or 2% are from the county south of there. But that can, give all kinds of information about what does this imply for where the need is and where might you want to focus other machines if you have resources to do more than one. Then the other graphs and charts and tables are showing, this one is the distribution by county, just broken out by the city or the municipality. And, this Littleton, the big orange bar is the one where it's located. Down here, it's sort of more the traffic. So it's the peak hours. You have times of day, and you see that afternoon between noon and 6 is the time when most of them are dispensed. And in particular, 2 p.m. is a popular time. Not so much in the evening. And then this is day of the week. So Mondays and Wednesdays are big access times, and not so much on the weekends, which surprised us. We thought, based on some of the literature, that weekends and evenings were going to be the times when people would access the machine because they don't have access to somewhere else where they might get the product. But so then we kind of think about, well, what it might be going on. So this is located right outside of a building that has a lot of different services. People are coming, going all day long. And so it's kind of convenient, I would think, during working hours if I'm imagining maybe there's a group at 2 p.m. on Mondays and Wednesdays, and that's why there's just a lot of people going in at that time. So it's more convenient for them to just use the machine on their way in or out instead of coming later. Oh yeah, and then the bar graph here is interesting because it shows the trend line over time of how many boxes were dispensed. Very popular in the very beginning, the first few weeks, everyone is there, it's exciting, it's a novel thing, and they're using the machine a lot, and then it kind of leveled off. And then I'm not sure what explains that, but this was July when this report came in, so it'll be interesting to see what happens over the next few weeks by the next time the report comes through. Okay, so what do we know about vending machines? So this is a clever title. There's absolutely no downside to this, except for community opposition. A qualitative study of the acceptability of vending machines for harm reduction. So this is real. Different communities have different amounts of opposition. And, there's opposition to harm reduction all over the place. But The opposition seems to vary depending on what the product is. So people are more opposed to syringes in the machine than naloxone, more opposed to medications for opioid use disorder than fentanyl test strips, for example. So this article and some others have given some suggestions for how to try to minimize the opposition in the community and kind of prepare for the installation before it happens. So community education is big, and talking to people one-on-one, which in rural areas, thankfully, is easier to do than in big cities, and just kind of conversations that explain the rationale why we're doing this. And also coupling the machines with safe syringe disposal and information about how to get treatment. So there are things, compromises, additions, things we can learn from the community about what makes this more appealing to you and how can it be better. But you'll still have people who say, you know, why Narcan? Why not, you know, insulin or something that a different group that's less stigmatized might need or want. Okay. All right, so this is other syringe. Okay, so syringe vending machines have been around for a while in Europe, a couple decades. They have not, they're only recently here. So we do have some data from syringe vending machines. And research to date does show that presence of vending machines increases access to supplies and reduces needle sharing. It does not result in increased drug use. And interestingly, the vending machines don't replace the supplies that are distributed elsewhere. So before the vending machine goes in, often there's a pharmacy people could get it from or a SSP. And when the machine goes in, one of the studies was able to, you know, measure all these things, how many are being distributed by all these places. And the vending machines were giving out more Narcan on top of what was already being given. And on this study was syringes too, but it suggests it's reaching a different population, people who aren't the ones who are going to the SSP or the pharmacy. So they looked at the kind of the characteristics of people who are more likely to use a vending machine are people who've never accessed harm reduction supplies before, younger people with more unstable housing, it's more likely used on the weekends, the less likely to have been on MOUD in the past year, less financially stable, and more likely to access this daily as opposed to going to a pharmacy daily. But one, you know, it's really great that these vending machines can provide the supplies. However, like one downside that people advocate for is if someone gets their supplies somewhere else where they're interacting with a human, that's an opportunity for that person to get, you know, potentially get hooked into treatment, get information, you know, just make that connection that might lead to the next good step on their path. All right, so that's our vending machine. The other innovative distribution that we've done is both xylazine and fentanyl test strips. We do give out test strips, but we also give out this is the the PDF of the way this thing gets printed, but this is becomes a folded wallet card that has information for people who use the strips on how to use them and some suggestions too about what you can do to have safer use, like using with other people, using a small amount first, and the actual steps for how to go through the test and then the test strip and how to interpret it, and a disclaimer too about laws. So different states have different laws about whether these can be distributed. These different like strips, for example, they're considered drug paraphernalia in some states and therefore are illegal to be distributed, which we didn't know until we started distributing them. We thought, oh no. So that's why we did the disclaimer, because Cora can't keep track of where everything is going and what the laws are everywhere, but we put the responsibility on the people who receive the supplies. So we have this wallet card, and we have a micro scoop, a little plastic scoop that holds 5 to 10 milligrams. And this was really helpful to me because you read these and you don't have a sense in your head, at least I don't, not being a chemist. like what is 10, what's 5 milligrams of 10, how much do you actually have to use of your product to get the test? And thinking, well, who's going to want to give up some of their product in order to do a test on it? Will people really use these? But then you see this tiny little scoop and it shows you how much you actually have to use. So we give the scoop, we give a little vial of water. And so they have kind of everything right there that they need, the strip, the water, the scoop, and like this is, sterile water, and they can take all the steps and do it at once instead of somebody who's on the street and doesn't have access to water. How are they going to use, the test? So that's our other innovative thing. We do give out other supplies in addition to the naloxone and the test strips. We give backpacks, some of which are locking. Many of the people that our clients serve are unstably housed, and don't have a secure place to leave their belongings. So that's why we offer locking ones. CPR masks, drug deactivation bags are things we might have some out on the table. We do, Jenny's telling me. It's a plastic pouch, and I think it has charcoal in it. And if you have medications that you don't want, and you don't want a child in your home to have or stumble upon, or a pet or whatever, you can put the medicine in there with water, seal it up, shake it, and you can't open it again, and it's deactivated anyway, and somebody really tries to get in there. Lock bags, like zipped bags with locks on them, boxes like the metal boxes that open again for people to have safe storage. Wall-mounted overdose prevention kits. These are called Nalox boxes. It's a brand name, and it's probably about the size of the computer. It's about this big, and you put it on the wall. It's sort of like you have an AED machine, or you have your fire hose or whatever that you would have for emergency situations. And inside of it is I think it's got room for 2 boxes of naloxone and like a breathing mask and, safety seals. So in order for this to work well, there has to be somebody who has a stash of naloxone and can check every day and resupply. You don't want to have like an empty box sitting around. So that it's nice because it's convenient, but it does require some monitoring. We also give out sharps containers and syringe clippers. So we have quite a bit. I'm going to, at this point, just kind of step back, way back again to Cora. And I've given you a little slice of what we do, but really we've had a big impact. We started our funding in 2019. And to date, we've supported over 35,000 rural healthcare providers across all 50 states. Each pin represents color-coded in what ways we've served that state. I just told you about the yellow things, technical assistance and supplies. But we also have healthcare provider support and training. And one of the things that we do is called office hours. So every week on Thursdays at noon, we have 2 of our addiction specialists, board-certified addiction psychiatrists, available to talk to anyone who wants. Rural providers, that is, any rural provider who needs advice about or has questions about how to treat people with any substance use disorder. It's free service. So I want to get the word out there. And then another thing that we have done a few times, and we're right now in the process of planning the next one, is our scholarship program. And that is, the application's open until like Monday. So it's very timely. We have offered this program to up to 3 different primary care practices. This year, we're focused on primary practices in rural Vermont counties who are they're under-prescribing, or haven't really started prescribing, or they want to get more comfortable doing it. And so we have 2 days of instruction, not just on prescribing and MOUD, but other diagnosis and treatment and motivational interviewing. And we do case consultations. So it's a really nice jam-packed 2 days of support around prescribing and treating people in general with opioid use disorder and other substance use disorders. So that is what I wanted to convey to you. And I want to make sure you can see that the email, you can either talk to somebody out in the hall. We have a table there. Our email is easycora@uvm.edu. You can request support on our website, which is easy too, uvmcora.org. Request support or uvmcora.org. Subscribe to our newsletter. And you can, this also, the QR code will get to the website where you can subscribe to the newsletter. So I'd be happy to take questions. Thanks. Yeah. He's asking where it was in Southern Vermont. It was in Bennington. And they were just covered like the Bennington, I mean, it literally just happened. So I think last week Bennington Banner has an article about it in case you're curious to know like where it is and stuff. I mean, you can get one, not from us, because we were funded to do 5 and our 5th one is already, underway in Maine. So sadly, no, but and I wish go ahead.
Was fine. Where else would like
I was just about to say, I'm not sure that I know a source of others, but Jenny just left, but maybe I can talk to her about how to try to do some research on that. Yeah. Excuse me.
Hi,
Hi.
thank you for your presentation. I was wondering, you mentioned that you're talking with healthcare providers about connecting patients with replacement therapies. And you also mentioned Narcan precipitated withdrawal.
Mhm.
And I was wondering if there's any effort from your organization or others that you know of to connect patients in intensive care who have just been administered Narcan with replacement therapy to account for that precipitated withdrawal state.
So you heard the question because thanks for putting it in the microphone. So it varies a lot by hospital. And I know at the UVM Medical Center, we do have, I forget what it's called, but it's an acronym. In the emergency department, they can start buprenorphine. STAR, thank you. It's STAR. So they will start, but you have to then follow up. What you probably, maybe you know more than I do, 2 or 3 days, and then you have to follow up with a primary care provider. But as far as like ICU, is that what you meant for?
Yeah, just in general, folks, maybe coming off the street who have been administered Narcan, then
Yeah.
being, put back out with no replacement therapy. I could imagine that's a really uncomfortable spot to be in. So just
For sure.
about that.
I mean, that's an issue with like right now we have a lot of, unfortunately in Burlington, a lot of different emergency situations responding to opioid overdoses. And you talk to first responders who keep going back to the same place multiple times a day, sometimes the same person, and if there's precipitated withdrawal, then the person is in withdrawal, and if the drug is available, they'll want to, avoid those withdrawal feelings, of course. I think going through an EMT, depending on like if you get into the hospital, is probably easier to manage that withdrawal than if you're out on the street and just getting an EMT coming.
Yeah.
So yeah, but Cora, to answer the other question, Cora doesn't really get into that.
Okay, thank you.
Mhm.
Great presentation, Gail.
Thanks.
I was curious, the addiction psychiatry consult service that you offer, how often are you guys being taken up on that? It sounds like a wonderful opportunity, and I just hope people are using it.
Absolutely. We thought it would just be floodgates and we'd be turning people down. We haven't had as many as you might think. We got maybe, we had like, I think word got out and we had like maybe one a month, honestly. And then what we've been noticing now is, so we have that scholarship program, as I mentioned, where we had 3 different practices come for our 2 days. And those folks who got to know us really well, they're the ones who are more likely to call because they feel comfortable. They know who we are. Other people might feel intimidated. I'm not sure why, or they just don't know about it. We've tried to spread the word, but we've decided going forward that we're going to incorporate that into the scholarship program as a follow-up.
Great.
So they'll get their 2 days and then we'll just like roll them into doing the the office hours. if
Yeah,
they're-
yeah.
if they
So
want.
almost like you have to do an outreach to get providers comfortable with using your knowledge or calling on you. Very interesting.
Yeah.
Alexa Anderson, one of our online audience members, asks or says, fantastic presentation. Would love to hear your thoughts about how to support community partners in overcoming the stigma about harm reduction in rural locations. Currently seeing that in rural Wisconsin. Is there a place on the website for best practice recommendations with the harm reduction vending machines?
Okay, great. A couple things there. Stigma is a very big issue, especially in rural areas, as you point out. We do have resources about stigma. So in addition to what we just talked about with the talking to providers and having the scholarship program on site, we do have a lot of resources that we've developed, like data briefs and like our newsletters and information. I can't remember what we call them all, but a lot of written materials, and a lot of them are about stigma. And we have our community rounds workshop series, which are all recorded online. People can go to the website and just watch. We have at least one, I think 2 or maybe even 3 that are related to stigma. The information of best practices for starting, that's a great idea to put it on the website. We're just starting to like assemble that with the idea that we want to write a paper about our experience with the rollout of all 5 of these. So that's not yet on the website, but I imagine that once we kind of get things together for a lit review and whatnot, that we could share that.
Thank you very much.
Yep.
Can I ask a question?
Sure.
So based on your map with all the pins,
Yeah.
it's so impressive, the dissemination of this approach. But have you, if there was a community that was willing to pay for these things, have you calculated what it would cost for a community to be able to implement these processes? Because it's like, people leaving out, there are some rural communities that are pretty well off and wouldn't necessarily need, a government grant or something like that to put this in place. So I was just curious whether how much it would cost to put that in place.
That is a fantastic question. For those who didn't hear, just how much might it cost to put all these together if they weren't provided by a federal grant? A community might try to DIY. So, I mean, we could kind of add it up, like the vending machine, I don't know, $11,000-ish. The supplies of not, like, I think we could just do the math and try to add it up. But we haven't actually done that. But we would be happy to share the information if there was a rural community that wanted help with that, we could do it. Yeah. Thanks for your attention and all your great questions. We're here. As I said, we have a table. I'm around if you want to ask other questions later. Thanks, everybody.